So let's get started with CHF. This is patients with cardiac disorders. So let's jump in and get her done. So these are the theory objectives. We want to compare left-sided to right-sided heart failure and understand that. Discuss the treatment for the systolic and diastolic heart failures. Apply a nursing assessment and what we're going to do and identify life-threatening heart rhythms from the selection of cardiac rhythm strips. So this will be interesting. We're going to learn a little bit of strips, but you don't really have to identify strips in your NCLEX, but in the clinical setting, it's good to know some of the basic strips. So I do want you to understand. So this is the most common cause of heart failure is coronary artery disease or uncontrolled hypertension. So if you have high blood pressure and it's not controlled, and even though you feel fine, whatever's happening, this can cause congestive heart failure, and we don't want that for folks. But this is what makes it a silent killer. So there are signs and symptoms of left-sided failure and right-sided failure. So add this to your notes. Right-sided failure pushes fluid to the body, causing edema and peripheral edema and even pitting. So what happens is it's pushing fluid that way. Left-sided, think lungs, L for L, and that's, if it's left-sided failure, it's where we have fluid back up into the lungs, and that's where we get the drowning in our own fluids. So that's the difference between right and left. Here it says fatigue and shortness of breath for left-sided. That's where we get it first noticed with activity and while lying down. And that is a sign. If you're short of breath while you're lying down, you shouldn't be. Right-sided failure, weight gain, pitting edema, that's a biggie. Highlight that. Liver enlargement, jugular vein distension. Where if we sit down, these veins will pop out. If you ever see it, you'll never forget it. And reduced urinary output. That comes with the right-sided failure. Of course, it breaks this down. I'm not going to read it to you, but I do want you to know the difference. So remember, L is for lungs. That's where it backs up into the lungs. The right-sided failure is pushing fluid out. It's pushing, and because it's pushing out, it's causing edema and pitting edema. So we can push down, and there's that indention that stays. There's the difference between the two. So goals of our treatment, we want to reduce the demand of oxygen and the workload of the heart. We have to take the workload off the heart. It's a big, fat, flabby muscle. Here was our heart, all natural and normal, just pumping away, pumping away. When we get congestive heart failure, we're in heart failure. What happens is the muscle's been worked and worked and worked, that it gets big. And because it gets big, it's ineffective. It can't get a squeeze like it should. So we're not going, and it depends on what side. We're either going to be pushing fluids out, causing all this pitting, edema, and issue, or we'll be on the left side, putting it back over into the lungs. I do want you to understand that by giving different medicines, we can reduce the demand of oxygen and the workload of the heart, and that medication is dobutamine. That is the drug of choice for congestive heart failure. It's an inotrope, and it's going to help make the heart more effective. There's a dose that they give for heart failure patients. Strengthen, we want to strengthen the heart's pumping action. That's why we give this medication. Relieve venous congestion in the lungs. We have to. We cannot be fluid overload. That's why you hear those crackles and stuff. Minimize sodium and water retention in the tissues. And how do we do that? Well, we can give medications to do that, but we also need to be diet controlled. So watching stuff. So if we're in complete heart failure and we get to the point that it's going to be death, you can be put on a transplant list. And one of the things that they can do is they can put you on, it's called an LVAD, or a left ventricular assist device. And this is one that you'll go to Vandy. They do it at Vandy, and these patients walk around, and truly what's happening is the heart is outside of their body. So they go in and they cannulate into the aorta, as you can see, and they'll come back and cannulate on the other side of the heart. And so what happens is when blood flows in, it's actually happening out here in this canister, and then it'll be shuttled back in, and then it's able to be pumped out. So no matter what the heart is doing, if you're on monitor with this, they could be in sustained VTAC. It doesn't matter because this is actually pumping. And so because of that, they stay alive and they're able to hopefully sustain life until they can get a heart transplant. And you can stay on these for a pretty long time, but there are always, when you do anything like this, there could be issues or problems. There are other LVADs that are used that are not small like this. They're at bedside. I actually took care of patients on LVADs. It's the heart is out, the ventricles are outside of the body. They're just there, and the atriums. You can have 4 chambers, 2, whatever they decide. You can have right-sided, left-sided. They have BiVADs, RVADs, but this is a left ventricular assist device. So you know, kind of interesting. Patients do survive. If they are cannulated quickly enough, they can survive and for a long time, and then hopefully get that heart transplant. So we can have cardiac dysrhythmias, and we can see these with patients in failure. But what they are is alterations in the conduction of the electrical part of the heart. This is where the electrical part, you've got a pump issue with the actual failure, but you're going to start to have electrical issues, and that's where we get the cardiac dysrhythmias. It's the disruption of the normal electrical conduction in the heart, and we'll just have abnormal rhythms. So they can have lethal arrhythmias where they can have things that won't sustain life, or they can have rhythms that are not conducive or helpful to the patient or client and need to be controlled with medicines or converted or whatever we need to do so that they will be okay, if that makes sense. So let's do our first question. The nurse is about to administer the first dose of furosemide. It's an IDE, that's Demodex. And all the IDEs, remember, are your loop diuretics. It's furosemide, furosemide, that's Demodex. It's a diuretic to a patient diagnosed with congestive heart failure. Common drug reactions include what? Shortness of breath, it can. Chest pain, it can. Lightheadedness, it can. It doesn't cause hypoglycemia, and it doesn't cause hypertension. It can cause hypotension because it's going to pull volume off the body. It's a loop diuretic. Don't forget, loop diuretics are potassium wasters. So that's our concern. If you see an IDE, think loop diuretic, and when you think loop diuretic, think potassium waster. Always thinking that way. Okay, so this picture here is just a review of your cardiac conduction system, and it's a good thing to know. You learned it in anatomy, you need to go back and review it. You have your SA node, and that is where we have the initial firing, electrical firing of the heart to get the heart. The atrium's going to fill. I have a whole video on this alone. This is what creates our heartbeat. Go back, you can listen to it. It's on the YouTube channel of the heartbeat and how it works. So there's a filling of the atrium, we'll go to the ventricle, it pumps up, it goes over, it gets oxygen, it comes back in. I mean, but here is the actual electrical part, and you can see. So if we have the SA node here, we have our AV node here, a bundle of His, and based on where it fires and the electrical activity starts is what the rhythm we will see on an EKG. So if we bypass, we don't have an SA node, we're not going to have a P wave. Do you see? It's bypassing because something is causing a block, an electrical interruption. So we need to just understand, kind of look at the anatomy of the heart. You can see how these come down. We have a right bundle down here, left bundle over here. So if we have bundle branch blocks, we'll have them here. And there's the Purkinje fibers. They go all the way to that apex, right, of the heart. This is the strongest part of the heart, of the muscle. It's that bottom big pump that needs to be. We get failure, this gets big, fat, and flabby, and it doesn't want to do what it needs. So cardiac dysrhythmia, signs and symptoms. Bradycardia, just remember, is anything less than 60 beats per minute. Tachycardia is 100 beats per minute or greater, right? Anything greater than 100. But with a dysrhythmia, we can have dizziness, palpitations, chest pain, hypotension and loss of consciousness, and even death, depending on the rhythm. So we need to have a normal heart rhythm so our heart will pump normally. So remember, if we're sinus brady, we're slow, right? We see it with heart blocks. You don't need to know heart blocks. I'm not going to teach you heart blocks. If you go into a cardiac unit or floor, you will learn your heart blocks. We have 1st degree, 2nd degree, and 3rd degree blocks. These are taking place at different places in the electrical current or firing in the heart of the electrical part of the heart. If we're too fast, we're going to have SVT, that's supraventricular tachycardia. It is a tachycardia, but it is fast. Ventricular tachycardia is coming from the ventricle, right? Supra is above and ventricle is that bottom. So they look different, similar but different, and there is a different time frame. You will not need to know that. And then we have atrial fib. And I do want you to know atrial fib, and I will teach you the rhythms of those, because atrial fibrillation we see all the time. And our biggest worry with AFib or atrial fibrillation is stroke or clots, because what happens is it's firing, it's just not doing what it needs to do, and then every so often it will fire and that will cause a contraction. So you have this erratic, there's no P waves, it's this erratic part it's fibrillating. It's like, and then finally it'll go, and it gives us a thing. But what happens when we're fibrillating, the blood stays stagnant, or stasis happens, and it causes clots like on the valves. So when it finally does pump, if there's clots there, it just showers clots. The heart will just shower clots out and can go to the brain, to the lung, wherever. It'll go to the brain, causing a stroke. So atrial fib, what we want to do is we want to control it. It can be controlled by rate. So some people are chronic AFib, they're going to live in this forever, but they always need to take an anticoagulant so that they don't throw clots and they are prone to have stroke. So we want to prevent stroke by that. So once again, atrial fib fibrillates, blood stays pooled, and then finally when it contracts, if there's clots formed, they will shower out all over, causing stroke. If that's the case, we want to make sure anybody that's atrial fib is on an anticoagulant, right? Because we don't need them to form clots. We need to prevent that coagulation piece so that they don't throw clots and have a stroke or anything detrimental to them. So this is up here. I'm just going to mention it. It's not going to be tested on, but absent pulse is VFib. And I do want you to understand that. There is no pulse to VFib. It's fibrillating. The ventricles are fibrillating. We have nothing going on, and the ventricles are going, right? So you're not going to palpate and feel a pulse. This is pulseless. And this is emergent intervention if we're here. Premature beats, you can see them. Sometimes we'll have PVCs where we have these premature ventricular contractions. You get this big wide thing all of a sudden, it pops up. Atrial contractions, they're a little narrow, they come beforehand. And then there's PJCs, and that's a whole nother ballgame when we get into junctional rhythms. But for right now, the one I really want you to know is VFib, and I also want you to know AFib. So we're going to learn the fibs. I kind of like it. Anyway. So if we're having these arrhythmias, we can give different meds. Lidocaine is one we can give. If it's an arrhythmia, the heart's irritated based on an MI or something like that, or there's some irritation to the heart, we can give lidocaine. And lidocaine is a numbing solution. It does the same thing to the heart. It kind of numbs it, and that will stop those arrhythmias or dysrhythmias from happening. We can also want to give that anticoagulant based on what the rhythm is and different things like that. We can give inotropes to help with the pump, to give it a bigger squeeze, to offload the workload. There's just all of the ACEs and ARBs and beta blockers. They all, not only do they lower blood pressure, but they do affect the heart, and they do in a positive manner. So lots of times they will be given these drugs for this reason. Cardiac pacemakers, we can put a pacemaker in if we need to, if they're too Brady or they're not having a P wave. we can actually put a pacemaker in, and so if the heart rate slows way down, it senses it and it will actually fire and start to give a paced beat. Now, electrically, the pacemaker will fire, but the muscle has to contract with it. So even in death, if a person has a pacemaker, excuse me, they can have the firing, the electrical part will fire. You'll see a line on the EKG, but it's flat and a line because the patient is gone. The heart's not going to pump. But normally you'll see a line on the EKG, and then you'll see a P wave if it's atrially paced. If it's ventricularly paced, then you'll see a line and you'll have the complex, the QRS complex. So that's what we see. We can cardiovert if we can synchronize on and actually get them out of these arrhythmias. It's an electrical, of course, it's our defibrillator, and what we do is no matter what, if you're going to cardiovert, it must be synchronized. You don't just fire it up and shock them because you can put them into asystole. So what we have to do is it has to be put on the monitor itself of the defibrillator to synchronize. It will synchronize, and then when it's ready to fire, it will tell you, and you push it and will fire on the synchronized beat that needs to be. So you don't throw them into asystole and kill them. Implantable cardiac defibrillators. These are AICDs. You see ICD there. These are implanted, and what happens is if you start to have a lethal arrhythmia, you go into VTAC, it will defibrillate internally. It's implantable, and it internally actually will defibrillate you. And so they feel it, it gives it a kick, but it just restarts the heart for them and stops that lethal arrhythmia. They're actually a really good thing. Sometimes you can have both AICD that will pace and defibrillate. So we see that kind of side by side a lot. And then we can ablate, and we have a couple people that are in our class that understand ablation, but they can go in and actually stop those rhythms. So if you have this atrial fib that's uncontrolled, they can go in and kind of ablate and cause it. What it does is it will create the pattern that it needs to go. It stops what's happening so that you can have a normal rhythm, or it can control the rhythm depending. So this is a thoracic placement of a permanent pacemaker and transvenous pacing wires, and you can kind of see it's small, but it's there. This is the pacemaker. They're very small. Nowadays, we can actually just on the phone check them. They don't have to come in and do all that kind of stuff. There was a lot that used to have to be done. They last for a good long time. You can usually see them above. They are up kind of high, the actual pacemaker itself, but the wires are down and implanted in the heart so that when it fires, it's going into where it needs to in the electrical part of the heart. So this is a great picture of pericardial effusion. We talked about that with the MI, but we see, as you can see, the heart cannot expand to fill. It's showing you this. Backup system in circulation, decreased output to the body, decreased blood flow to the lungs. It's just not good. The heart can't do what it needs to do. So this is actually fluid around that compresses the heart wall. So you have your pericardium, your myocardium, and then your pericardial cavity. But this little sac that goes around the pericardium, that is what fills with fluid, and when it does, it compresses the wall of the heart, and you have a pericardial effusion. This has to be, it's emergent, and it has to be taken care of immediately, or the patient can actually have a decrease in cardiac output and go into cardiogenic shock and die. This is where the muscle is, the heart itself is being held captive, encapsulated, and it can't pump efficiently. So cardiomyopathy, this heart gets big. It fails, it's trying, it's worked, and you get this big fat heart. And it's just not going to function. It's a group of diseases that affects the structure or function of the heart, and that's what happens. Different things happen to it, and that's what we call cardiomyopathy. Drugs to increase contractility is DIG. We see it again. There's antihypertensive drugs that we can use, diuretics, antiarrhythmic drugs, and anticoagulants. We can also use some inotropes. Dobutamine is used too to kind of help with a little bit of the pump if we can. Heart transplant is the end all of this. And the really sad thing that I find with cardiomyopathy is you can see it with pregnant women. I never had a patient, I've done hearts for a long time, and I never had a patient until I moved to Savannah, Georgia, and there I ended up having 3 30-something-year-old women in full cardiomyopathy failure post-baby. And so it was very, very eye-opening and very sad. It was very sad. But heart transplant, they can be put on the list, and a young person like that would be. But we would have to do everything we can to help them. So once again, whenever we don't have flow, if you don't have blood flow, if there's something going on and you have an increase of oxygen demand, which is going to increase the heart work, the workload of the heart, we want to give oxygen. We want to put oxygen on these people, so they need oxygen therapy. We're going to give them digoxin, but we want to watch for digitalis toxicity, and that's where I talked about it, really low bradycardic, and we can give Digibind, which binds with it to get it out. That's the antidote for digitoxicity. But what we want to do is if they have visual disturbances and some other things, that's that digitoxicity, and you need to know that. Dietary controls, remember the DASH diet, low sodium, low fluids. We're going to watch. When we have this, we have to eat healthy. This is difficult for people and can be very expensive, so it's something to definitely discuss with patients. People don't realize how much salt's in a can of soup. We did an activity back, you guys did it with me, my students, but just for those who are listening, we did this activity where you wrote down everything you ate the day before or whatever, and then you added up looked it up and found out how much salt your intake was. And then some of us were just shocked. We just didn't realize what we were consuming. So it's definitely something, it's a teachable moment. It's a moment that you need to reinforce. Read your sodium levels, best to do fresh if you can with everything, and lay off the salt. And salt substitutes, not good.